And welcome to the short video preview of our online webinar which I'm doing with experts running Physio Tom Goon on the 31st of May. Is looking into chronic gluteal pain in detail, looking into the common presentation condition, and also looking at the red flags associated with this region. So for further information, please visit www.physiouk.co.uk/ben. We're looking into the relevant clinical anatomy, looking into the common red flags which could be present in this region, and also referred pain from the lumbar spine or the SIJ. Most importantly, we'll be talking about local pathologies, which is the deep gluteal syndrome, piriformis syndrome, and ischio-femoral impingement. We'll be looking into the etiology, clinical findings, and rehab implications, and also looking into the current literature of managing these pathologies. Flags in the gluteal region. One of them is sacral stress fractures. It's important to recognize them, although they are not common, because the symptoms can often mimic sciatica and can lead to delay in diagnosis and treatment. Most of them is due to increase in training load, and usually the patients are intolerant to impact activities and also to sitting, and it can also lead to normal x-rays, because this type of stress fractures are usually difficult to visualize on x-ray and tend not to produce callus. So the patient group I'd be thinking here would be the master endurance athlete, the 40 plus, and also the female athletic triad with low BMI and poor nutrition. Presentation of hip pathologies. So if you look into a young active population with hip impingement, the most common presentation is your C sign, which is in the groin region as well as in the lateral hip. But it's important to remember that nearly a third will also have buttock pain or going into the low back pain. Multiple case series have shown that around 20 to 30% of patients with articular hip pathology will have an element of buttock pain or pelvic pain. So it's important to remember that it might not just be groin pain which be linked in this population group. In the subgluteal space, we've got the piriformis, we've got the gemelli, we've got the obturator and the quadratus femoris. The sciatic nerve emerges from the pelvis, and it's usually midpoint between the ischial tuberosity and the greater trochanter. It's vulnerable to compression at the level of the piriformis. The majority of the population, the sciatic nerve passes underneath the piriformis, but around 20 to 22% it pierces where it's vulnerable to compression. To diagnose entrapment of the sciatic nerve in the subgluteal space is the active piriformis test. The patient is inside lying, and the hip is flexed to 50 to 60 degrees, the knee at 90 degrees. The patient actively pushes against the resistance, and a positive test is the reproduction of pain around the greater sciatic notch, which is usually the region where patients with piriformis entrapment have symptoms. And looking at the literature, this test, the active piriformis test, has a sensitivity of 0.78 and a specificity of 0.8. So we use this along with the seated piriformis test to confirm the diagnosis of sciatic nerve entrapment in the subgluteal. Useful going through some of the key points which we'll be covering on our online webinar, which is on the 31st of May. It'll be recorded, so you could access it anytime, even if you're not able to attend it. So we hope that to see you there, and for further information please visit the link. Thanks for your time. Bye.